Assalamu alaikum. Let's dive into a very high topic called brain herniation. In herniation type, there is subfalcine herniation, uncal herniation, central herniation, and tonsillar herniation. These subfalcine herniation, that means herniation of the cingulate gyrus. There is herniation of the cingulate gyrus under falx cerebri. There is no pupillary development and consciousness often preserved. This patient in subfalcine herniation, 1 point consciousness preserved. There is herniation of the cingulate gyrus under the falx cerebri and another consciousness is preserved and there is contralateral leg weakness. That means ipsilateral ACA compression. There is contralateral leg weakness. That means ipsilateral ACA compression. Now, look at this high topic. Important question. A 13-year-old man is brought to the emergency department. Why? Due to head injury. The patient was climbing a tree when he fell and injured the right side of the head. She briefly lost his consciousness after the injury. On arrival, the patient is awake and reports pain over the right frontal area, but no focal neurological deficit. There is no focal neurological deficit. That means consciousness is intact. CT scan show right frontotemporal epidural hematoma. We know that epidural hematoma is lens shaped. Uh, Epidural hematoma is lens shaped, not crossing the suture line, lens shape, not crossing the suture line, and rupture of the middle meningeal artery, lens shaped epidural, not crossing the suture line, and rupture of the middle meningeal artery. Neurosurgery is consulted for craniotomy for evacuation of the blood. While waiting for surgery, the patient becomes somnolent and develops left lower extremity weakness. Initially, there is intact focal neurological signs. The patient's consciousness is intact, but now patients become somnolent and develops left lower extremity weakness. Look, in CT shows right-sided problem, right frontotemporal epidural hematoma, and weakness in the left side, left lower extremity. So looks like right ACA is compressed. That's why left lower extremity weakness. There is no pupillary problem. Like in ankle herniation, there is third nerve, oculomotor nerve, maybe compressed, but in here there is no eye involvement. Which of the following is best explains that this patient's worsening neurological status? So it looks like subfalcine herniation. It is not subarachnoid hemorrhage. It is not tonsillar. In ankle herniation, there is third nerve palsy. There is third nerve involvement, compression of the third nerve. Okay, this is subfalcine herniation happens in here. This is AC anterior cerebral artery. Look, when this subfalcine herniation happens, this ACA is get compressed. That's why right ACA compression, left sided weakness is happen. Okay, the patient with traumatic epidural hematoma develops soreness and left lower extremity weakness while awaiting for surgery. Her acute deterioration is concerning for brain herniation, a potentially fatal condition that can occur. A potentially fatal condition that can occur when hemorrhage expansion, the mass effect cause a portion of the brain to protrude through an opening in the dural fold. Subfalcine herniation when the cingulate gyrus, a medial gyrus of the cerebral cortex just above the corpus callosum, is pushed beneath the falx cerebri, uh, usually due to an unilateral frontal parietal and temporal lobe lesion frontotemporal epidural hematoma because the brainstem and associated cranial nerves are compressed. are not compressed. Brainstem and associated cranial nerve are not compressed as they are in other herniation syndrome like uncle and tonsillar. Subphalangeal herniation does not cause pupillary involvement. It does not cause pupillary involvement. It does not cause the third nerve, oculomotor nerve compression. There is no irregular respiration. Very, very, very high yield. As because the brainstem and uh, associated cranial nerves are not compressed in this herniation. So in here there is no irregular respiration, there is no coma due to reticular activating system compression, and there is no pupillary involvement. As subphalangeal herniation progresses, however, ipsilateral SCA compression to ipsilateral can lead to contralateral leg weakness. So right SCA causing left-sided weakness. Okay. Diagnosis is typically made via CT scan, and treatment focuses on lowering the intracranial pressure and correct the mass effect like hepanotoma evacuation to prevent further herniation progress. Okay, now uncal herniation. Herniation of the uncus. What is uncus? It is medial temporal lobe. Herniation of the uncus under the tentorium cerebelli. So herniation of the uncus under the tentorium cerebelli. In here there is ipsilateral dilated and fixed pupil. Ipsilateral dilated and fixed pupil due to ipsilateral oculomotor third nerve compression. Early contralateral hemiparesis ipsilateral cerebral peduncle compression, and in late cases ipsilateral hemiparesis. So in early cases there is contralateral hemiparesis due to ipsilateral cerebral peduncle compression, and in late cases there is ipsilateral hemiparesis due to contralateral cerebral peduncle compression. So that is uncal herniation. So uncal herniation, pupil is dilated and fixed. Pupil is dilated and fixed due to ipsilateral third nerve compression, oculomotor nerve compression. In early cases, contralateral hemiparesis. In late cases, ipsilateral hemiparesis due to contralateral cerebral peduncle compression. If we look at this question, this 23-year-old man is found unconscious at the scene of a motor vehicle collision. Okay, left leg deformity, large laceration on the left temporal skull. So left temporal skull is involved. As the patient is being rolled onto a backboard, he regains consciousness. He regains consciousness. So he actually lost consciousness. Now he regains consciousness. He recalls no detail of the collision but reports a severe leg pain. He reports a severe leg pain, headache, and some shortness of breath. Severe leg pain, headache, some shortness of breath. Blood pressure 90 by 60. So hypotension, not that tachypnea. Peripheral IB excess is often 1 liter fluid is given. On the way of hospital, patient develop progressive weakness of the right side of the body. There is progressive weakness on the right side of the body. So there is left sided lesion, left temporal scalp swelling, but now there is right-sided weakness. So right-sided weakness, and it becomes obtune. On arrival, the blood pressure is 160 by 90, hypertension, uh, bradycardia, and bradypnea. Looks like Cushing has just started. Which of the following nerves is most likely be compressed on this condition. So it looks like it is Cushing triad and left temporal scalp is injured. So epidural hematoma can happen, and there uh, is due to ipsilateral cerebral peduncle compression. There is contralateral hemiparesis. So looks like ankle herniation. In ankle herniation, there is third cranial nerve. In ankle or tentorial herniation, there is a third cranial nerve. So oculomotor nerve can be compressed. This patient who has sustained head injury in the left temporal region, scalp laceration, become unresponsive after lucid interval, likely has epidural hematoma. Epidural hematoma, lens shape, rupture of the middle meningeal artery, rapid expansion of the epidural hematoma can abruptly increase intracranial pressure. There is Cushing triad, hypertension, bradycardia, bradypnea, compress the temporal lobe. When this ankle herniation is happened, there is ipsilateral fixed and dilated pupil. Why? From compression of the ipsilateral third nerve compression. There is contralateral hemiparesis, progressive right-sided hemiparesis. There is contralateral hemiparesis, progressive right-sided weakness from compression of the ipsilateral cerebral peduncle of the midbrain, which damages the descending corticospinal tract. And there is contralateral homonymous hemianopia with macular sparing from compression of the ipsilateral posterior cerebral artery. Okay, as the herniation pushes the midbrain toward the contralateral side, the contralateral cerebral peduncle may also be compressed against the tentorium, causing ipsilateral hemiparesis. Very, very, very high. In the late case, there is ipsilateral hemiparesis. It's a false localizing sign known as Carnohan phenomenon. So, as the herniation pushes the midbrain towards the contralateral side, the contralateral cerebral peduncle may be compressed against the tentorium, causing ipsilateral hemiparesis, a false localizing sign called Carnohan phenomenon. Now again look at this question, the 4-year-old boy sickle cell disease. Okay, I'm now look the gist portion. The patient is sleepy and requires painful stimuli to remain awake. So his consciousness is lost. So consciousness is deteriorating. On neurological examination, what is happening? Left pupil is 3 millimeter with normal pupillary reflex, but the right one is 8 millimeter unreactive to light. So there is involvement of the third cranial nerve. Looks like ankle herniation, and the most important part in here, in epidural hematoma, there is epidural hematoma. It is lens shaped lucid interval, not crossing the suture line. Left lens shaped lucid interval. So this patient is drowsy, progressive drowsy and headache. Okay, he lay down on the ground for several seconds but do not got up and continued walking and talking normally. So there is lucid interval after his consciousness is lost. There is again regain of the consciousness, that is lucid interval. So there is lucid interval, looks like epidural hematoma. So patient classically have a brief loss of consciousness followed by a lucid interval of minutes to hour. Rapid hematoma expansion leads to deterioration of the consciousness, somnolence, and symptoms: headache, vomiting, and elevated intracranial pressure. Without treatment, worsening intracranial hypertension can result in ankle herniation. Signs is ipsilateral pupillary dilatation due to oculomotor nerve compression, contralateral hemiparesis. As the herniation progressing, there is ipsilateral hemiparesis, which is a false localizing sign. And this is a biconvex density, lens shaped biconvex lesion, epidural. And subdural is, we know that in subdural it is crescentic shape, subdural crescent shaped hypertensity crossing the suture line. It crosses the suture line. There is effacement of lateral ventricle, mass effect. There is effect of the lateral ventricle, that is mass effect. Okay. Now again look at this question. In this there is CT scan is given. So it is lens shaped by convex shape, not crossing the suture line, looks like epidural hematoma. So emergency neurosurgical intervention should be done. Emergency biconvex lesion that do not cross the suture line and emergent neurosurgical hematoma evacuation should be done. Finally, this question: a 61-year-old farmer is brought to the emergency department unresponsive in the barn. Okay, on examination, he does not respond to stimuli, so consciousness is lost. There is no evidence. Okay, people is mid-sized, do not respond to light. So peoples are mid-sized, not respond light. So looks like, and arms and legs are rigid and held in straight out. The toes are pointing toward brief. Toes are pointing downward. Brief extensor and plantar reflexes, brief bilateral extensor plantar reflexes are present. Looks like brain herniation. Okay, we have studied the cephalus and herniation, ankle herniation. Now there is central and tonsillar herniation. In central or in tonsillar herniation, look here, in central herniation and tonsillar central, caudal displacement of C, caudal displacement of diencephalon and brainstem. So C and B, caudal displacement of the diencephalon and brainstem. So there is bilateral mid position and fixed people. Bilateral mid position and fixed people. A loss of sympathetic and parasympathetic innervation. There is bilateral mid position fixed pupil and caudal C comes with the D, like decorticoid and decerebrate portion. Decorticoid is flexure portioning. Decerebrate, cerebrate is extensor portioning. There is rupture of the basilar artery, rupture of the paramedian basilar artery branches, and finally the tonsillar herniation, herniation of the cerebellar tonsil through the foramen magnum. There is coma, loss of cranial nerve reflex, flaccid paralysis, respiratory arrest. In tonsillar there is coma, loss of cranial nerve reflex, flaccid paralysis and respiratory arrest, Okay, look here, this patient has herniation, brain herniation. There is rapid increase in intracranial pressure due to intracranial hemorrhage leads to, this is the central herniation. This patient is central herniation. Why? There is bilateral, people size are mid-sized and do not respond to light. Mid-sized response to light. So this patient likely has central herniation, a type of herniation, CD, diencephalon, and the midbrain, and becomes caudally displaced through the tentorium cerebrally. The herniation not only compress the brainstem, it not only compress the brainstem, but can stretch and rupture the paramedian branches of the basilar artery, resulting in further ischemic injury. Common findings of central herniation is unconsciousness. This patient has unconsciousness due to dysfunction of the ascending reticular. In here, there is unconsciousness, but consciousness is intact in subphallus and herniation. In subphallus and consciousness is preserved, but in central C for consciousness is lost. Consciousness is lost. There is mid-sized fixed people due to impairment of both parasympathetic and sympathetic nerve fibers innervating the pupil. So in here, bilateral, sorry, mid-sized people, why there is both sympathetic and parasympathetic nerve fiber is lost, and abnormal limb posturing due to disruption. There is decortical and decerebrate posturing, that is calling abnormal limb posturing due to disruption of the descending tracts, rubrospinal, vestibulospinal, typically involved in reflexive and postural movements. These commonly begins with decorticate flexure positioning with the damage of above the midbrain red nucleus, but often changes to decerebrate extensor posterior brainstem injury. So cerebrate extensor posturing as brainstem injury and decorticate above the level of the midbrain, above the level of the midbrain red nucleus. Treatment focuses on decreasing the intracranial pressure, correcting the underlying etiology, intracranial hemorrhage evacuation to prevent the tonsillar herniation. It is why to prevent the tonsillar herniation, which can compress the medulla. So central herniation can finally can cause tonsillar herniation, can compress the medulla and resulting in cardiac and respiratory arrest. Okay, finally, in a short, all the herniation is a very, very, very high topic. This is subphalangeal herniation. Look at subphalangeal herniation. Sorry, in subphalangeal herniation, look in here anterocerebral artery. So ACA can compress right. ACA compression can cause left-sided weakness. So in subphalangeal herniation, ipsilateral ACA compression can cause contralateral weakness. Uh, Subphalangeal, then ankle herniation. In ankle herniation, there is third nerve compression, oculomotor nerve compression, third nerve compression, oculomotor nerve compression. There is contralateral hemiparesis due to ipsilateral cerebral peduncle compression, and there may be ipsilateral hemiparesis due to contralateral cerebral peduncle. And when it happened, it is called Carnohan phenomenon. And the finally the so subphalangeal herniation, ankle herniation, central herniation. Central herniation can cause decerebrate and decorticate. Decorticate is flexure posturing and decerebrate extensor posturing. Decerebrate extensor posturing and decorticate flexure posturing can happen, and it can cause the compression of the brain stem. It can cause compression of the caudal midbrain. Okay, and finally, the central herniation can progress and can cause compression of the tonsillar herniation, where there is coma, loss of all the cranial nerve complexes, reflexes, and flaccid paralysis, respiratory arrest. In central herniation, one thing we have to remember, there is bilateral mid position fixed people due to loss of sympathetic and parasympathetic nerve innervation. It's a very, very, very complex topic, but if we read in this way, we can deal with the questions. Okay, hope you enjoyed, inshallah.